Hello, my name is Dr. Andrew Siegel. I'm a urologist who practices out of Hackensack, New Jersey, and today I would like to talk to you about management of urinary symptoms from prostate enlargement. This slide depicts antiquarian art showing the treatment of a man who cannot urinate, which at one time was placement of a hollow reed into one's penis and into the bladder in order to alleviate the obstruction. Fortunately, we have come a long, long way. Let's talk a little bit about the prostate gland, a mysterious organ to many people. What is it? It's a gland. It is primarily an organ of reproduction. It completely envelopes the urethra, which is the channel going from the bladder out. It produces a nutrient vehicle for the purpose of nourishing sperm. And the prostatic glandular fluid, or milk, is released via the prostatic ducts at the time of ejaculation. Benign prostatic hyperplasia, also known as BPH, also known as prostate enlargement, is a very common problem among men that can cause bothersome symptoms that can interfere with daily activities, and particularly sleep. It is typically correlated with the aging process, with testosterone, the male hormone, and with one's own genetics. Chances are, if your dad had a problem with his prostate gland, you very well might have a problem as well. The illustration on the right of this slide shows normal anatomy on the left and benign enlargement on the right. And essentially, in the normal process, you see the prostate surrounding the urethra, but a nice channel and a normal appearing bladder. In the right, there is prostatic enlargement such that the prostate encroaches upon the opening of the urethra, narrowing it. And as a result of this obstruction, the bladder gets thicker and much more muscular, just as any muscle does when working against resistance. Now, the process of benign enlargement typically starts around age 40 or so. The prostate is typically the size of a walnut in early adulthood and then increases to a variable extent thereafter. And as the prostate grows, it puts pressure on the urethra, giving rise to the annoying symptoms that we will discuss. Now, there are two factors, a static factor and a dynamic factor. Static factor refers to the obstruction from the mechanical presence of tissue occluding the urethral opening, versus the dynamic factor, which refers to the muscular contraction of the prostate that can vary over the course of time, which can also contribute to the problem. This is a very nice cystoscopic slide that I took of a patient on the left at rest, that is, while he was storing urine, at the right when he was emptying his bladder. And you can see how the prostate actually opens up nicely during the act of voiding. It doesn't do such in a situation when there is obstruction. Blockage or obstructive symptoms are typically a hesitant stream that is weak, of narrow caliber, stops and starts, causes prolonged time to emptying, and often causes incomplete emptying of the bladder. Additionally, there are other symptoms that are probably more annoying than the obstructive symptoms, called irritative symptoms, including urinary frequency, getting up at night, which can be very sleep disruptive, urinary urgency, the sudden desire to urinate, and also at times urinary urgency incontinence, in which one cannot get to the bathroom on a timely enough basis to prevent leakage. Now, I mentioned earlier the bladder compensates. The bladder adapts like any other muscle in response to increased resistance by muscular thickening, just as your biceps respond to the resistance of lifting a dumbbell on a regular basis. And the slide on the right depicts the cross-hatching ruffles and ridges appearance of bladder compensation, known as trabeculation. If prostate growth continues unchecked and the bladder thickening maxes out, a process called decompensation can occur, in which the bladder actually distends, urine is retained, the bladder muscle stretches so much that it loses its tone and cannot empty, and then a situation develops called urinary retention. And in fact, a decompensated bladder can back all the way up to the kidneys, causing what's called as hydronephrosis, affecting kidney function, causing kidney insufficiency or failure of the kidneys to work properly. This next slide shows the result of chronic prostatic obstruction on the bladder and the upper urinary tract. Now, many men have benign enlargement. When should we treat it? Well, when the symptoms interfere with your quality of life. That's a very compelling reason. If you are retaining urine, if you can't empty, if you have recurrent urinary tract infections, if you have bladder stones, since your bladder is not emptying well, and stones can form because of the mineral content of the residual urine, if the kidneys are not functioning properly as a result of the obstruction, or if there is bleeding of the prostate due to the enlargement and the increase in the blood supply that can ensue. Patients with mild symptoms, or even with more severe symptoms that are not bothersome, can be managed with watchful waiting. There are medications, there's minimally invasive surgery, and standard surgery. There are two main classifications of medications for BPH. There are alpha blockers that essentially relax the muscle tone of the prostate, and there are 5-alpha reductase inhibitors that can shrink the prostate. Alpha blockers include Hytrin, Cardura, Flomax, and Uroxetrol, and the 5-alpha reductase inhibitors include Proscar and Avodart. Combination therapy in which an alpha blocker and a 5-alpha reductase inhibitor are used together is often employed. The alpha blockers typically are effective very quickly since they relax the smooth muscle of the prostate. The 5-alpha reductase inhibitors work more slowly but can really reduce or inhibit the natural course of prostatic enlargement and are also useful for preventing prostate cancer. Minimally invasive treatment can involve microwave therapy, transurethral needle ablation, and laser photovaporization. This depicts microwave thermotherapy similar to the microwave in your kitchen. The prostate is carefully heated up to create a channel through its core. In similar fashion, transurethral needle ablation uses radio frequency waves to create an opening. In my opinion, the laser photovaporization, known as the PVP or green light procedure, is the most effective means of minimally invasive therapy for prostate enlargement, and is essentially under direct cystoscopic guidance. A laser is used to create a channel through the core of the prostate, and this shows the green light on the left, the appearance of the prostate before the procedure, and then 3 months after the procedure. At times we do an incision of the prostate in which an electric knife is used to make an opening in the prostate at the 5 and 7 o'clock positions. At other times we do a transurethral resection of the prostate. Transurethral resection is an operation that has largely gone by the wayside, being supplanted by procedures such as the green light PVP. It's still an excellent operation in which the core of the prostate is opened up using an electric loop that is drawn through the prostate that removes the core of the prostate in piece-like fashion. Open prostatectomy is occasionally utilized for an extremely enlarged prostate that is not amenable to minimally invasive therapy. So the goal of medical or surgical treatment is alleviation of the disturbing and annoying symptoms of prostate enlargement and prevention of some of the potential dangers and pitfalls that can ensue as a result of prostate obstruction,